Okay, so this is our regular monthly webinar for bariatric surgery, and we offer these services in Tijuana and Guadalajara, Mexico. And we're going to get started again. If you have not filled out the health questionnaire, the HQ, please go ahead and do so. If you have, you don't have to worry. And all you have to do is watch the webinar to the end and be present. We draw the raffle at the end. Please pay attention because we try to answer the commonly asked questions during the presentation. And if you didn't hear the answer to your question, of course, you're welcome to add it to Q&A tab. When we get to it at the end of our presentation, we'll try to cover as many of your questions as we can. The link to the payment for deposit is you can find on mexicobariatriccenter.com/make-a-payment/ and the vitamins we offer you can find on emergebariatrics.com. The topics that we cover today is we cover what is obesity, what are the risks of being obese, what does weight loss surgery offer, and what does MBC offer. MBC is Mexico Bariatric Center, of course. We know what we're doing. And bariatrics, then we will cover all the bariatric surgery options. Dr. Valenzuela at that time would take over and explain laparoscopic, endoscopic, all the options from gastric sleeve to bypass to duodenal switch, all the options. And then, of course, the emerged bariatric vitamins, which is essential for taking after the weight loss surgery. And then we get to the question and answer. And then we would do the raffle for $2,000 off of the package. So obesity is a chronic disease and needs chronic treatment. And this epidemic is global and is affecting US as well as the rest of the world. And basically what we're facing is high calorie abundance of food in our society, of course. And the food has high calorie and all the sugary drinks. There you go. I can see you now. Hello. And and then throughout the human history, we have not been faced with a situation that we don't have enough physical activity because we are just sitting behind our desk or in the car traveling from work to home. And then also, you know, the high calorie foods and processed food, which they call ultra processed food, sugar drinks, these are all attacking us day to day. So, of course, a lot of the obesity comes from genetics and how we are inheriting our genes from our parents and ancestors, but also the environmental exposure, developmental history. These are all factoring, as I mentioned, you know, increased nutrient content of food, abundance of food, fast food, sugary drinks, lack of physical activity, stress eating, you know, that's huge. When we're tired, when we're stressed, we get home, we want to eat to comfort ourselves. Inadequate sleep, which we're all facing, and a lot of us are not getting enough sleep. That's contributing a lot to weight gaining. And of course, some of the drugs that we take, those are all contributing to our weight. And as a general idea, they define this formula, which they call body mass index and BMI, that you basically plug in your height and weight and gives you a number. And that kind of puts you in a range to know, like, if you're normal, that's a BMI of under 25, and under 30, you're still normal in an overweight, area. And then after 30, you start getting to the obesity zone, and then morbid obesity and super morbidly obese and super morbidly obese. These are all the high BMIs more than 60. One thing about knowing our center is that we can handle any BMI even up to 100, over 100 too. So there is no limitation of what we can do as far as BMI concerned. And of course, we all built differently. Our bones, how strong our bones are or how dense our bones are. These are all determining factor of knowing whether we in the obese zone or not. But in general, BMI is a determining factor. And so what obesity does is extra fat is not only we gain weight, we get more fat tissues or fat cells or adipose tissues. The structure of our fat cells or adipose tissues also is altering after we gain weight. And that you can see on the right side of my screen that how a lean adipose tissue structure is different from an obese adipose tissue. And these are all causing insensitivity to insulin, which is diabetes type 2, insensitivity to leptin, which we don't feel satisfied. We don't have the satiety after we eat, and we don't respond to therapies and vaccination as well. And so before we thought like, okay, if we gain weight, we just add more fat cells, but it's not true. The fat cells tissue structure also changes. Obesity is a major risk factor, and it's impacting 40% of people in the US, of course, worldwide, but this is we're talking about US only. This is an animation that shows what happens when we gain weight in the abdomen. It pushes our lungs, it affects our breathing, as well as so many other organs or places in our body. This animation shows what happens.
Look at this. Our diaphragm is one of the major muscles that helps with breathing. Breathe in and the diaphragm contracts and the lungs expand to take in oxygen. But if you're obese, fat in the abdomen can push on the diaphragm, limiting how much air you take in.
Again, other what we call comorbidities, which is multiple effects of obesity in our body, is heart disease, the stroke, diabetes type 2, like I mentioned, lung disease, impaired immune system, chronic inflammation, blood clots. And during COVID-19, we experienced how obesity can actually be a higher risk factor for people getting exposed to COVID, as far as catching it, as far as ending up in the ICU and death. And the reason, of course, the more fat cells you have, the more places you have the protein receptors of COVID to get attached to, therefore you're more susceptible to catch it and get affected by it. So here's a subject of, okay, so how do we deal with obesity and being overweight? Of course, classical living healthy idea of diet and exercise. Diet and exercise is great. Exercise is always great no matter what, but is not a long-term solution for obesity. And we're going to see later on why is not. And basically, not a whole lot of people can lose 50, 60, 80 pounds by just diet and exercise. So that's not a long-term solution. So what is left is pharmaceuticals. So all the diet pills, the fad dieting like Atkins, and now the Ozempic injections, all those also is not a proven long-term solution for obesity. We talked about obesity is a chronic disease and it needs a definitive solution. It needs a long-term solution. And there comes bariatrics. Weight loss surgery is a quick, safe, and long-term solution. And we'll see why. Of course, we can cover Ozempic is becoming widespread. A lot of celebrities are using it. And this is a medication that was actually made for diabetes type 2. And people experience weight loss with it. And now people who are not diabetic are using it to lose weight. And it comes with a lot of side effects, like you could get thyroid cancer, inflammation of pancreas, changes in vision, low blood sugars. So there's so many allergic reactions that you can get from this if you're not diabetic and take this medication. And again, because obesity is a chronic disease, you need to have chronic treatment. And obesity with drugs and medications, you have to take it indefinitely. And if you stop, you gain the weight you lost plus more. So it's not a long-term definitive solution. We say, well, why is diet and exercise not working? This is a good way of explaining what happens when we go on diet, when your body starts slowing the metabolism, and you get more hungry because your body thinks you are in starvation threat. So you get more hungry, you want to eat more, you don't burn fat as much, and you don't have the satiety decreases too. Again, this is the way to explain the difference between diet, exercise, medication, and injectables or whatever against bariatric surgery. So let's say an individual is weighing about 250. At 250, your body metabolic system, your brain, gut hormones, all the hormones actually are interacting around that weight, which we call body's thermostat or metabolic system, or however you want to call it. Your body is used to that weight. If you go on an extreme diet and intensive exercise, we're talking about boot camp type of exercise, and let's say you lost 75 pounds, your brain still used to that body's thermostat at 250. So what is it going to do? It's going to resist the weight loss by making you more hungry and lowering your metabolism. Because it feels like I'm going into the starvation mode, so I need to store food. Now, the difference between diet and exercise and medication versus bariatric surgery is once you go through the surgery, because of your hormonal changes, and it's not resisting the hormones. It's changing the hormones once for all. You wake up from the surgery, your brain and your hormones are interacting at a different level. Right away, your thermostat is lower to 175 pounds now, because that's how your brain sees it. So what's going to happen is the reverse is going to happen, which means your hunger is going to go down and your metabolism goes up. You burn fat, you lose fat, and you lose weight rapidly, and you don't get as hungry as before. So that's why we say bariatric surgery resets your metabolic system, your gut hormone and interaction of the gut hormones with your brain. And that's how you get a second chance in life. It's a life-changing experience. So the question now comes, how do I get this life-saving surgery or procedure? Of course, some insurance companies cover, but the ones that are not covering, or you don't have insurance, or your deductible is more than what you pay to come to Mexico to get the surgery with us, then the medical tourism is an option, which means you come to us, we facilitate your travel, you go to Tijuana or Guadalajara, get your surgery, and you come back, all managed with the driver, with staff, with surgeons, hotel, all the reservations. So we basically coordinate your transportation, all your movements down there, from pickup between hotel, hospital reservation, hotel reservation, surgery, of course. And if you see the CDC recommendation for going abroad, which is medical tourism, for medical travelers, they recommend that you work with a travel medicine provider that pick you up at the airport, does all the hotel, surgery, center reservations and arrangements, and you can check the reviews and you can see what kind of quality of care they provide. And most important, if they offer medical tourism insurance, which we're going to cover some soon when we talk about our packages. So when you come with MBC, you are using our 10 years plus experience with over 20,000 patients and successful surgeries. This is what you get coming with us. It's interesting to talk about social media. Social media is great, but it also has its, I don't want to say dark side, but pitfalls. So you see some exaggerations when these internet influencers go online and try to promote something. And as much as, it's useful, it could be also misleading, because if somebody puts a before-after picture, a surgeon puts a before-after picture, it could be a fake picture, it could be a Photoshop picture. You don't know what's the infrastructure behind all this. So you need to really dig deep and find out, is this a legitimate company? Is this a trusted organization? Have they been around for a while? Do they have support before, after? Can I get something after my surgery from them? And do they have a support group? These are all the questions you need to ask. And as a matter of fact, in Mexico, well, the Mexico COFEPRIS, which is the federal government that overlooks all the medical services, is really tightening the rules down there, and are really cracking down on a lot of the surgery centers that are not legit or they are not up to code. And one of the other things they're doing is they are actually asking to be certified to do social media advertising because of all these advertising going around, and they're not really true, or they are fake, or there's so many mishandling of the media. So down there now you have to be authorized to actually be able to do social media advertising. So Mexico Bariatric Center has been around for more than 10 years. We are a US-based corporation in Sacramento, California. Our mission since the inception has been to provide highest quality of weight loss procedures in Mexico with the most affordable prices. These are all the pluses of why choose MBC. Our reviews, our reputation, our surgeons, the surgical teams, of course, our all-inclusive packages, safety, ease of scheduling with us, support before after surgery, or we are a Better Business Bureau, we are Medical Tourism Association certified. We have a US surgeon liaison on our staff, nutritionist on our staff. And we do offer what no company offers is medical tourism complication coverage. Of course, is optional, but we highly recommend that. So what we did was we tied up with the top company who provides these services, and we got a deep discount for our patients. Continuing our journey to provide top quality services, we've been working on a project for a few years now that we call Hospital Azar, and this center should be soon ready to be utilized by our patients. We're basically looking at 3 floors of state-of-the-art facilities for hospital, and it's going to have more than 40 rooms and 4 operating rooms, of course. And we are very excited to be able to work with this soon. These are some of the pictures of the center that we're working on. Well, this is kind of a sample video. Again, some more pictures of the center, and actually, this shows early on when Dr. Valenzuela was visiting the construction site. This is during COVID when we had to actually wear masks. Again, Mexico Bariatric Center has over 10 years of experience in medical tourism. Myself, I've had over 15 years of experience in medical tourism. and 20,000 plus surgeries, 7 top quality bariatric surgical teams. Our packages are all inclusive, includes the surgeon fees, hospital, hotel nights, and medical tourism insurance, again, is optional, but that's a great service that we are offering in our packages. To book with us is very simple. 1, 2, 3. Basically, you fill out the health questionnaire. Once you get your approval, you can choose a date, pay the deposit. You are on our books and scheduled, and you just book your flight and finish your paperwork. You are on your way to get down there and be on the losing bench. One of the pluses, again, that I mentioned was our support groups. We have several support groups. 2 of them are the ones, one over 10,000 patients, and one is few thousand. The one that is what we call inside Facebook group is for people who are on the fence. Of course, some of our patients are on there too, but those are for the people who fill out the HQ and they want to know like what it's like to be going through surgery and what it's like to go through MBC to get surgery. We have a team of our past patients, what we call affiliates, or basically supporting you. Sarita, Rena, Kelly, Megan, and Dawn. These are past patients that are working with us day in and out. They actually have a podcast that I recommend you watch. It's very informative. Rena and Sarita are doing that, at least once a month. And so the process, once you get on the calendar and you book your flight or you arrange for your driving, your driver is going to be there in San Diego International Airport. That is actually going through some construction. Terminal 1 is actually a mess, but if you come with Southwest, you end up in Terminal 1. Any other airline, you will be ending up in Terminal 2. The driver is going to pull on the sidewalk and pick you up after you get your luggage. Of course, we recommend that you don't pack light. You don't want to bring a lot of stuff, with you. The weather usually nice in Tijuana, which is more like San Diego around the year. Doesn't get too hot or too cold. Of course, there are some exceptions, but we want you to arrive before noon. That gives us enough time to do your pre-ops and everything else. And you stay in the hotel, and your departure time should be 2. I see some people joined after we started. So if you have not filled the HQ, please go ahead and do so. Be present to the end of the webinar, and we will do a raffle at the end. One of the other advantages of going with us is you have a team of surgeons that cover anything from endoscopic to laparoscopic, from gastric balloon to duodenal switch to SAVES and RNY and mini bypass, all the type of revisions, ESG. So basically, you're talking about the best of the best. These are the most experienced, most certified, most knowledgeable, skilled surgeons you can find. And Dr. Miguel Montalvo, Dr. Louisiana Valenzuela, which we have the honor to have her here with us today, Dr. Alejandro Gutierrez, Rodriguez Lopez, Dr. Jacqueline Osuna, and Jesus Ceja. We take pride in our HQ approval process. Patient submits the HQ. It goes through our surgeon liaison. Like I mentioned, this is a US surgeon liaison who is bilingual and studied medicine in Guadalajara, one of the top schools in Mexico. And she's sitting right behind all the HQs and interacting with our surgeons. We basically route your HQ to the best match for your health, type of health, your BMI, your age, the type of surgery you're looking for, and find the best match for you among our surgeons. And you make sure, you know, this is you're basically teamed up with the best option. And of course, our certified nutritionists and patient coordinators are there to support you. Our pre-op diet is pretty straightforward. Basically, depending on your BMI, you may have anything from a 2-day clear liquid to a few weeks of pre-op diet. Pre-op diet is important because, first of all, it shows your commitment to go through the surgery and keep up with it. And it makes the surgery so much easier on you and the surgeon. So the better you do on your pre-op diet is easier on you as well as the surgeon. The 2-day clear liquid is pretty much common among all the BMIs, and you just have to go like 850 calorie a day, just salad, protein drinks, and fish or chicken. Again, this is our team down there. One of the components of your stay is the hotel night. When you actually arrive, you stay in a hotel to be fresh for the next day to have the surgery. We use Hyatt, and alternatively, we use Fairfield Marriott if we don't have room in Hyatt. So like I said, you stay in the hotel first night you arrive, and they tell you what time to show up in the lobby the next day to get picked up to go to the hospital. Your companion stay with you the first night, stay in the hotel when you leave. There's free breakfast for them. You get, of course, unlimited broth, Jello, and ice chips before and after surgery. On the day of the surgery, they take you to the hospital. The surgeon comes and talks to you again, make sure that you don't have any questions. The surgery is the best option for you, and you can always have that consultation. You stay 1, 2, 3 nights based on if you're a gastric balloon, sleeve or bypass or DS, and they do multiple leak tests, and you be ready to fly back home. They pick you up again and take you to San Diego International Airport to fly back. Success rate and complication rate being low is one of the factors, is surgeons' load management. We manage our surgeons' load daily, and we cap their surgeries at 3 to 4, depends on the type of the surgery and the complexity of surgery. And that's why we have less than 1% complication rate and a high success rate. I let Dr. Valenzuela take over, of course. Before I let her take over, I want to talk about, she's one of the most sought after surgeons in Mexico. She actually has had gastric sleeve herself, so she knows what patients look like, what is their experience before and after surgery. She's one of the only surgeons in Mexico with double board certification for bariatric surgeries, board certified. She's had over probably 7,000 surgeries. She limits her surgery 3 to 4 a day. There's not enough I can say about her, but she's a top surgeon. I'm going to let her take over and talk about bariatric surgery options. Of course, if you like to talk about yourself a little and say why you became a bariatric surgeon. Thank you, Dr. Valenzuela.
Hi, hello, everyone. Can you hear me enough, Ron?
Yes, we do hear you. Perfect.
Okay.
Thank you.
Okay, hi again. I have been reading all the questions here in your question and answers, and every question is very important to resolve because I know it's hard to take the decision to get the surgery. Like Ron says, I am a bariatric patient too. I understand better how the surgery works after my surgery, and I can share the experience and of course share my experience in the surgical room too, and recovery time and all the weight loss long-term experience, right? We have I have read all the questions, and one says how you are explaining everything about how we are fatty and overweight problems. Well, we need to understand how is the process and what is our expectatives, who is the important thing here, because we have maybe a different thoughts about the surgery. Some people think it's just magics. It's a really magic change, but this is a process, and this is a tool. We repeat a lot that to say it's a tool. Surgery, we need to understand the tool. It's working in a very, very magic process in the first years, but after that we need to know this is together with the patients, the tool with the patients process, who needs to restart the way to eat, the way to be in compromise and in a healthy diet and in a new style of healthy way to eat. And that is a successful long term too with the surgery, but the reality is a surgery, like Ron says, it's successful treatment for obesity, fast, safety, and long term to get resolving all these problems with the overweight, diabetes, hypertension, brain hypertension, problems with the hormones in the syndrome of polycystic ovarium, the fatty liver, the acid reflux, because the acid reflux is a problem, and well, a different kind of problems, health problems we have, and the surgery resolved that with the weight loss and with the itself procedure like bypass, who resolved the acid reflux. So we have different procedures in all our surgical life. We know different procedure who it's not more in the field surgery, because it's a history, like lap band. Lap band, it's not, we know it's not working enough, is not with a good results long term. It's giving us more problems than quality of life and successful in the weight loss. So we don't do more lap bands. We are doing just revisions. We are doing revision the lap band to bypass, to sleep, depends. So we are doing gastric banding surgery, yes, just for revision lap band to bypass or sleeve. We are doing more gastric sleeve surgery. It's all maybe 60% of procedures, 60 to 70. 40% of procedure is bypass, the malabsorption procedure like mini bypass, and duodenal switch and that kind of procedures. We are, our experience give us the different new procedures, who is not new, it's just the way to do it, who is the patient says mini gastric sleeve, but it's not the procedure. The procedure is a sleeve surgery, but the way to do is a less incision in the abdomen, in the tummy. In the past, we did 5 incisions all the time, and we are doing 3 incisions in some patients who it's possible because the liver is small and we don't have a obstruction in our way to perform the surgery. So we can do 3 incisions in some patients who is too good because it's less trauma in your abdomen, and it's less pain, faster recovery, and of course, aesthetic is better for the patient. And the patients are named that 3 incisions mini sleeve, but it's nothing to modify in the sleeve by itself. The sleeve is the same. 2, 3, 4, 5 incision is the same as sleeve surgery. The sleeve is the same technique. It's just the way the incisions in your abdomen, the difference. So the mini gastric sleeve, that is the mini gastric sleeve. To clarify that point, the single incision gastric sleeve is the same. It's just one incision, but is the technique to perform the gastric sleeve is the same. It's the gastric sleeve at the end. The same gastric sleeve is 80%. We remove the 80% of the stomach and you keep yours 20. It's the same for the mini gastric sleeve. It's the same for the regular gastric sleeve and for the single incision too. The difference is the way we go through the tummy in the cavity, in abdominal cavity. And we have the malabsorption procedure, who's are the gastric Roux-en-Y, the bypass, the mini bypass, the duodenal switch, the single anastomosis duodenal switch. Is the difference is the same like the bypass and mini bypass. In bypass, we do 2 anastomosis. We put the small bowel in the gastric pouch to get the food directly to the small bowel, but the bilis is cutting the way of the bilis to put down the bilis to join with the food down. So we avoid the possibility to get any bilious reflux in your gastric pouch. That is the bypass, the full bypass. And we count just 1.5 meters in the gastric full bypass. But in the mini bypass, we do just 1 anastomosis, but it's 2.5 meters with not food. So we jump more and mini bypass than the full bypass, but we don't cut the bilis way in the small bowel. So you could still have the chance or risk to get biliary reflux in the mini bypass. So it's low percents, but exist, and the patient needs to know this. So, well, these different kind of surgery, it depends how is your BMI, how much you have of BMI, and your age, your conditions, your general conditions, if you have or not acid reflux, if actually if the patients are candidate to get sleep bypass, mini bypass, or duodenal switch, and they don't have any contraindication to get any, we talk with the patients in all these possibilities, how is the most comfortable in their minds, and how they feel in the compromise to be on their diet, strictly vitamins and protein, and follow up in the doctors, nutritionist, because the duodenal switch, the study, the bypass need to be a little more strictly with the vitamins, protein, and with the follow-up meetings with the doctor. So the patients don't feel or feel a little scary, that idea to be in a strictly follow-up all the life, or under the strictly vitamins, protein, and checking all the time the lab test. So they choose better sleep surgery, for example, who is a little more kind in that aspect, who is necessary to be checking the first years, but after that, you will check in like the normal person, people in the world, no? Just checking the hemoglobin like any other people. The first years is when you need to be under strictly follow up, but after the 2-3 years, you need to be checking your hemoglobin, and if it's good, you don't need to do just your general primary care lab test like all people. So I try to saying that we classify the patients if the patients are candidate or not, depends if they don't have any, or if have any extra condition like this acid reflux or cirrhosis, hepatic cirrhosis, maybe because the fatty liver give you cirrhosis. But if you are in the first grade, we can do the surgery, but just the sleep surgery. So it depends what you have, what you expect, and what you want to, right? All these factors affecting the decision to take the best decision for every patient. Yesterday, I changed one patient from mini to full bypass because the patients have acid reflux. So I talked with the patients. She came to get mini, but I explained that the possibility to get biliary reflux with the mini, because she already had the acid reflux. So I explained the best option for her was full bypass to avoid the possibility to get more reflux, and she accept, and we did the full bypass for her. So another patient in the last week came, and he didn't know that he has affect the liver. He starts with cirrhosis in his liver. So we changed the procedure from bypass to sleep because it's not indicate to get gastric bypass in the patients who had this kind of problems. He was happy because we changed the procedure. We talked with the patient before they go to surgery, with everyone, to explain what possibility we can find in surgery, and if they are agree or not to get a different kind of options, depends what we find. So, well, we are doing a lot sleeve surgeries, but we are getting more and more full bypasses who are a very good surgery. I think it's one of the excellent tool in the all the procedure we are doing, because it's in the middle. It's not too aggressive. Is avoiding the possibility to acid reflux, resolving diabetes, and a lot of patients have problems with the high glucose, and we have this good option, who is the full bypass. So I don't know if you can change the slide. Well, we are talking about how the surgery help us with the weight loss long term, who is our main expectative, I think, in all our, we have all the patients that we have problems with overweight. We are having the big impact when we get the surgery. In the first 2 years, all our overweight, it's gone. We are seeing the excellent change. Our quality of life improves a lot. We resolve the problems with the fatty liver, with the glucose, with the hypertension, with the all your problems you can have, we resolve in the first 2 years. But we need to understand we are doing this change to care the change and care our surgery. So we need to be in the same channel with the procedure with your tool, to be changing step by step our way to eat, our way to care what we eat, choose the correct food, and stop to eat liquids with high calories. That is a big problem in a lot of our patients, because we have revisions too, who the patients lose all the overweight and regain it weight at the end. They don't follow the compromise with continue eating healthy. And one of the thing they change or they don't take care enough is the liquids. It's the hypercaloric liquids, like coffees with creams and that kind of Starbucks, different kind of sugar shakes in Starbucks, and or different presentations. I think the soda, the shakes, and all we take, it's a very dangerous to regain weight. So we need to care that aspect a lot. It's not by itself the food, it's more the liquids. The foods, of course, we need to care, but the protein in different presentation, that is good and is enough to feel satisfied when we eat. But I think we do more errors with the liquids. Okay, I read some questions too about if the surgery is safety for patients who are in the limit of the BMI. Oh, okay, we have a new one guidelines in the bariatric surgical field. We changed the numbers when we approve the patients to get surgery, because we know the overweight affect your style of life, and it's the way to be at the next step, like obesity grade 1, obesity grade 2. So we are preventing, and actually some people who had overweight, they already have problems with the glucose. So yes, if you are in the limit, we have a new guidelines. It's approved to the patients, even with 28, 29, 30 BMI, it's overweight. It's approving to get surgery too, because we know it's important to prevent, and not just that. Some people have problems with that overweight. So we are preventing. And the tool is to start the new style of life and get back the control in your how you eat, and controlling your lifestyle and your healthy lifestyle. Okay, well, the sleep surgery maybe is the most feasible surgery in the world. And we know some people have problem with acid reflux. We have different results who is contra and pro to sleep in the acid reflux. But the reality, we increase the pressure in your stomach, inside of the stomach, and that could have the push of the acid reflux to your esophagus. Sometimes, if the acid reflux is because you are eating too much and you are pushing in your stomach a lot of food, and it's acid food, like spaghetti, that kind of sausage, coffee, chocolates, and all that fatty food, fast food. Of course, any person will have acid reflux. And when you get the surgery, when you get sleep, you resolve, and a lot of patients will resolve the acid reflux because they change their habits and they change for a healthy diet, and that is the treatment for the acid reflux. But other patients who really have the anatomic problem, they have a hernia, a hiatal hernia, we can repair the hernia. In a lot of the cases, we don't have problems with acid reflux when we repair the hernia. But if you are a very several years with this problem, and it's a real problem, esophagitis, it's chronic, and at night you wake up with the acid of the food in your throat, then we recommend a lot the bypass, the full bypass. If you don't have any chance to, don't want to get any chance to get acid reflux, the best option is bypass. But if not, the sleep is a very good tool. It's a very safety and easy to be with the diet, the follow-up with the doctors, with the vitamins, with the proteins. It's easier, it's comfortable, and your quality of life it will be the same. That is important. The quality of life, how you expect in your life. But if you are different problems with diabetes, acid reflux, and others, the bypass is a very good option too. Could you give me the next slide? The next, well, a lot of patients ask, this is a very common question, the ghrelin and how the hormones involve the hungry, if it's reality that you will not have hungry nevermore, and that is not true. I want to explain this because it's not true that you never will feel hungry. The hungry is from different ways to the brain say, I am hungry. The ghrelin is one. The ghrelin is in the top of the stomach, the upper part of the stomach, and we cut that part. And we cut that way from our body saying to the brain, I am hungry, because the ghrelin send the signal to the brain when you are with the empty stomach or the full stomach, and we cut that part so you don't have anymore that signal to your brain. But it exists another signals, you know, the glucose, the low glucose, the hemoglobin low. It's another signal to the brain to say, I need to eat, I need to eat. So it's not just one, just help a lot, but it's not just that signal to the brain to say I am hungry or not, but help a lot. And that is the one part who help us, this tool to get off that signal, and it's feel not, or it's easy to feel satisfied when we eat, when we have a sleep, because it's a very fast to fall the little sleep. The next, please. Okay, see, single incisions. Okay, the single incision is for patients who had 30 to 35 BMI. And why? Because in that BMI, we know the liver is more chance to be small and don't have any difficult technique to get the liver all the time over the stomach to do the surgery. In our technique, it will be fine without the retractor liver. So we choose the patients. We choose the patients who had just 30 to 35 BMI to get this kind of way to do the sleeve surgery, the single incision. We can give warranty to, if you choose single incisions, to be single incision at the end, because we can know how it will be your liver. We suppose you will have the small liver, but it's not a reality in a lot of patients. So we explain that with the patients when they choose that way to do the sleeve surgery, the single incisions. We explain, in case we find a big liver or a big hiatal hernia who need to repair, we need to change the way to do the surgery to the regular sleeve, and that means 3 or 4 incisions more. So it's for patients who want aesthetic and don't have many scars. Okay, endoscopic gastric sleeve. It's a new way to do gastric sleeve surgery, in my opinion. It's for patients who are very scared to get gastric sleeve on another procedure, because we know it's easier, fast, and they don't need to be under hospital days. They want to be fast procedure and with low rate of risk. But we know the endoscopic gastric sleeve is not the ideal procedure. It's a lot chance to don't get enough restriction, because not the same like the sleeve surgery. I don't do this procedure, but a lot of patients wants to be under this because they are scary, a little scary to get the sleeve regular sleeve surgery or bypass. It's like the balloon. It's a chance to get your opportunity to lose some weight, but it will be not enough to. But if you saw people who had this experience and had good results, maybe works for you, but all depends. Everyone is different. Depends if you change your habits, if you change your, it's a different way towards this. It's more like your compromise in your experience in the procedure. This is easy, fast, and don't need hospitalization. So if you want to try, it's good too. Could you give me the next one? Well, I explained the gastric bypass. I think we can do the question and answers, and it will be better if I explain question by question.
Okay.
Because the patients ask about the bypass and different kind of procedures, and it's easier to be responded the different.
So they're asking, can I still have surgery if I'm overweight by the chart standard? Which means, if their BMI is more than 30, they can get the surgery, right?
Yes, I explained that already. So yes, you are candidate.
This person is asking, they've had a lot of acid reflux, and I chose gastric sleeve because malabsorption of the bypass makes me nervous. Is it safe to go with sleeve with existing acid reflux?
Okay, the best procedure for these problems is the bypass. And as like I explained before, it's not too much aggressive like duodenal switch or SADI. So I think if you are having, of course, a little scary about this procedure, you need to understand the acid reflux will give you at the end problems and very, very big problems with your esophagus, pre-cancer or something if you continue with your acid reflux. So the bypass, actually, a lot of patients with not overweight get the bypass to resolve the acid reflux, and that is the treatment. So yes, the bypass, it will be the best chance for you if you have overweight and acid reflux.
They're asking how many leaky procedures have you had? What happens if someone has leaks after returning home? What's the biggest risk? Septic shock.
Yeah, well, I of course I can't say we never had leaks, but I can't remember any sleep who licked me. The 2 or 3 patients I could remember, it was from bypass, and it was a very small thing who did they get a leak. It was a very tiny problem, and then we resolved in the same hospitalization. We know when the patients have a leak. We know when the patients are bad. We are always checking the patients. In all this experience, we just, when we see the face of the patient, we know he's not responding good in good way because all the patients are walking, are taking liquids, they are with the heartbeat in normal rates all the time, they are with not fever, they are talking, the face, the color, all these signs give us the patient is good. That are facts. The heartbeat under normal levels, the fever with no fever, the pressure is normal, they are breathing normal, and that all signs give us he's a normal patient with a normal evolution. So we knows when something is wrong and we act fast, we don't wait. I don't like to see what happened the next 2 days. I like to resolve. I know when something is wrong, when the patient is not in the way who's supposed to be, we act fast and we resolve all the time. I can't remember any patients who be at home with a leak because we can't saw the signal in the surgery after the surgery. So I can say this, our experience respond to see fast and act fast in case you have any problem. We can't say, actually any surgeon can't say, I don't have complications, because the complication is not because we have a problem in the surgery. It depends of how is your tissue, how what you had in the past, if you have healthy problems, or if you have another surgery before us. So it's different factors who involve this. But we can say we know when something is wrong and we act fast to resolve it. So don't be worried about that. Actually, I have 2 doctors working with me, plus my helper surgeon, plus my anesthesiologist, plus my internists who are checking and seeing all the red light, the red flags to be more attentive to the patients, to be more or to see if something is not good. So I can't remember any leak right now because a long time ago I don't have one. But yes, of course, could happen. But the good thing is we can know fast and resolve fast to don't be in a big problem at the end.
Thank you. So Maria asked, I produce kidney stones when I'm on protein diet. Will this be an issue to losing weight?
Maria, you can be a candidate to get sleeve surgery because the stone in the kidney is contraindicated to get bypass. If you are having this problem, I can say you won't continue to get this problem in the future, but you already have it, but the bypass increase. But the sleeve, we know it's a good procedure to get when the patients have these problems. So if you, without surgery, already have this problem, could happen with the surgery because you will need to get protein. So I think we can see it with your nephrologist, what is the best way, if maybe the hydration could be, or get ultrasound before your surgery to see what are happening. Maybe you have a disease behind to be more propense to get this problem. So I think, and I recommend to be in a study of that before you get the decision to get the surgery, because for sure you will need protein with the sleeve surgery, who is the best option for patients who had stones. We had patients with the stones and with the sleeve, and they don't have any problem. But exists the chance still.
You guys have I'm sorry. What does the aftercare look like for travel to help prevent DVTs, blood clots?
Okay, we have a lot of experience in that. We start the prevention in the hospital with Kexan. We start the walking immediately after surgery. I always ask my patients, please, when you feel wake up after the anesthesia, you need to start to walk. So we are the protocol, surgical protocol, who is the standard surgical protocol after the bariatric surgery. It's a new guideline too, to start the faster possible to walk, to start to the exercise breathing, to start with the blood thinners, to start with the oral way, just ice, but it's oral way, and the next day with the liquid diet. So you will see all the patients walking all the time, doing the exercise breathing, and of course you will need to keep your blood thinners for 2 weeks after surgery to prevent any clot at home or at your flight or wherever.
So they're saying, what do you do after you detach the stomach from the fat tissues? So after the sleeve, you won't flip around.
Okay, I am very, very I don't know what you are thinking about the surgery. The surgery, it exists a calibration, a technique, a specific technique to the gastric sleeve. It's a world technique. It's supposed to, all the surgeons need to follow up the rules to do the sleeve surgery. It's measures, a calibrate, and a way to do the surgery. We are doing the surgery with special staplers, special staplers, staple titanium material, is special suture over the line of cut. So we are doing the reinforce of the line of cut with the staple, with the staples, special staples. So we are doing the correct technique and reinforcing the line of the cut to avoid, to keep up the possibility to get any leak or any bleeding situation. And I especially do very strictly with my hemostasia in the surgery, because I don't like to use a drain tube. That is another question who has asked me very, very frequent. I don't use a drain tube in the sleeve surgery. And that means in my surgery, I need to be very strictly with the hemostasia. The hemostasia is the basals, the blood vessels. I cut the basals with the harmonic escapel, who is a device, special device to cut the basals. And after that, I put a titanium clip to close the basal as an extra precaution. So I can't remember any bleeding patient the last 3 years, I think, with the sleeve surgeries. When I start to be putting these clips and with no drain, actually the drain, it's a big relief to the patients that don't use a drain tube because they are breathing better. They can breathe deeper. They don't feel the pain all the time in their left side, and they can walk more. They have less nausea because the drain is a little aggressive. And some patients who are very sensitive from the drain will have a little more pain, a little more nausea, and could breathe enough deep. And so all my patients feels much better with no strain, and they are having faster recovery, faster walking time, and I see the difference.
Great. So they're asking, do you have the same drivers? Do you hire a lot of drivers? So we do have 2 teams of drivers that we've been using for years. One we have used for over 10 years, and the other one over maybe 7 years. Of course, you know, these team of drivers come with several people each team, and just you know, we just don't have anybody off the street. Just these are just people we've been working for a long time. They're asking, can I be on Mounjaro before surgery? Mounjaro is those diabetic injections.
Let me see. Yes, actually, we recommend to continue all your treatment the same like you are taking. Actually, it's very important you don't cut off your medications for thyroid, to glucose, to hypertension. That is very, very important to continue your pills for the high pressure. Yeah, we ask just to stop the blood thinners, and the blood thinners, the Advil, aspirin, naproxen, that works like blood thinners too. So we ask to cut that medication before surgery, but you will have to get normal that medication after surgery without problem, because all the patients ask me if they could continue to take Advil after surgery. Yes. And the medication for diabetes, it's a little unstable, because when you start the pre-op diet, you quit all this extra sugar, and some patients feel a little low sugar with the medications because they are not eating the same diet before when they start with the medication, or they are usually use the numbers, the glucose number in the blood. So we are saying you need to check your glucose, and you need to see if you are having this low rate of blood glucose, and then you need to ask to the doctor if you can reduce the medications, because we can give you an indication, because we are not saying how is your follow-up in your numbers. So please be in touch with your doctor when you start the diet, in the diabetic patients who are taking insulin or medications for glucose, because when you start the pre-op diet, you could have a little low glucose.
Sorry. So they're asking a lot about how much do I lose with gastric sleeve? would I regain the weight back? What would be my revision options?
I think I talked a little about this. We need to care our surgery. I say again, it's a tool, and the tool need to be careful for you, from you, and if you see you are getting a successful years from the bariatric procedure, and you say, I will continue eating like I want to eat, and no, like I need to eat to maintain my weight loss long term, or you will have a problem in 3, 4 years, 5 years after surgery. You need to follow up the recommendations. Don't eat, don't drink the same time. See your signal when you feel full and stop, don't continue eating. And all that recommendation we give to all patients, you will keep your weight loss, and you will need nutrition at the end. And you need to learn to eat, and at the same time you are losing weight, learning to eat, to don't be again in your way back. So that is all I can, and all the surgeons can say about the pregnant weight, about how care your surgery, because I like to say this is magic just in the first years, but after that is our work to care our surgery.
They've been asking a lot about recovery and what activities we can do after surgery. I just put up the slide, which shows like, what type of activity for each type of surgery, for like sitting, walking, lifting, yeah.
You will start your activity the first day, the first same day of the surgery. You will be walking. Some desk job is good to return in 1 week. Some other very light works, it's good to return 1 week, because you are moving a little and you need to move in, walking 1 block. And if you are moving in your work and it's not too hard, it's good to return. Of course, we need to be careful in hard works when we need to lift a lot weight, and we need to wait 6 weeks to start any workout, any heavy work exercise. I see the question who CPAP machine. You need to bring CPAP machine, please. It's very important you bring with you your CPAP machine.
So this question of how much weight you lose, and is bypass better than sleeve, and these are all just like you acquiring a tool that you can work with. So we see like our past patients, like how many gastric sleeve patients have lost all the weight they wanted, and they get to the optimum or their goal weight, and they keep it off for years. It just depends on your lifestyle, your diet, your nutrition, and everyone is different. Well, there are like that about 5% that they regain the weight, and of course, you can do a mini bypass or whatever to get back on track. There is another question they're asking: what is the bougie size that you use, and does that matter?
The boogie size we use is 34. That is the best size to get a sleeve. Some other countries use a 40, it's a lot, but we are having the successful surgery with 34 BMI, and it's the standard. I think it's in the standard. All the surgeons get the same French calibration, so don't worry about that. The important is to get off your 80% of your stomach and keep your 20, because we don't want to give you a problem. We want to give you a tool, a tool. The tool is this tool to get your enough restriction, but eating with not problems, because we don't want you get narrow zones or stuck food all the time. If not, just learn to eat with the restriction, with the enough restriction to lose all your overweight. And this is the magic. The surgery will give you this weight loss for sure. And you need to work. This is repeat. This is like Ron says, this is work together with the sleep. The first years, maybe not, but at the end, you need to learn to eat, because if not, you will regain it.
So they're asking about the vitamins and how long they need to be there. So the bariatric vitamins that we offer is specifically made for post-bariatric patients. You're getting exact formula of your body needs after sleep, bypass. For sleep, you want to be on it at least a year or two, and then bypass probably longer, and DS probably lifetime, just to make sure you don't have any bone density problem or any nerve damage long term, 7, 8, 10 years after. They've been asking about revision surgeries. You want to talk about revision surgeries? They've been asking a lot about like what type of revision surgeries we offer, like in general. Lap and revision or sleeve or bypass.
Well, depends. If you have a sleeve, we have option to get duodenal switch, bypass, mini bypass, SADI. Just we don't do a re-sleeve, because it's some people want to get re-sleeve, but it's dangerous because you are having a big scar in your stomach and not easy to heal the scarry tissue. And at the end, you could have an narrow zones, and at the end, you could have a leaks. So the options are bypass, mini bypass, duodenal switch, but depends. If you have well, mini bypass, you could have a full bypass, but it depends what surgery you already have.
Okay, so we still have like over 50 questions to answer. So if I have had gallbladder surgery previously, can the doctor go through my previous incisions? Or they just,
If it's our own way, yes. If it's very different because the gallbladder is in the opposite side, for sure we will need new ones. But some scar are in the same way. 1 or 2 maybe could be, but it's not a promise. But we try to use, of course, if we can, to don't do a new one scar.
I am on blood thinners. Will I have to come off for surgery?
We will give blood thinners after surgery, yes.
Okay, they're asking about PCOS.
Actually, it's a good question. We asked to all the women who had an fertile age to be under control pills to don't get pregnancy in the first, at least in the first year, because that kind of patients are usually don't take in nothing because they have a problem to can't be pregnant. But immediately when they have the surgery, it's the magic. A lot of patients get pregnant and they say it's because I never be under pill control because I never need it, but this is a big change. So you will have the change of the risk to get pregnant immediately when you get the surgery. So you will need to be careful about that and be under pill control. And it's a resolving magical. It's a good result with the surgery. These hormone problems resolving immediately the first 2 months after the bariatric.
They're asking, I had gastric bypass back in 1999. I'm guessing I will need a revision. And also, how long after pregnancy can you get the surgery?
The ideal time is 1 year after pregnancy. Even with cesarean, because you are in a lot of cases, you are given feeding your child, and you are depleted of hemoglobin, you are depleted of some vitamins. So you need to check that before you get surgery. If you was delivery very soon, so you need to wait maybe 8 months and check if you are good in your hemoglobin, if you're feeding your child. That is a good question too. Mm-hmm.
Again, they're asking which one is better, bypass or sleeve, about long-term results.
But long-term results, we saw it's the bypass a little more chance to get your weight loss long-term, but at the end, it will be, if you don't carry your tool, you will regain a little more weight slowly. But yes, bypass give us a little more rates to long-term than sleep. But some patients is incredible how the sleep have the long-term results. I have a patient who had 8 years with the same weight with the sleep, and so it depends to how you carry your surgery. And it's not just what you want. It's not what is your best surgery for you. Maybe, yes, you are a candidate to sleep or bypass or any surgery because you don't have any contraindication. So you need to check if you want to get the bypass. It's good. It's a little more long term. It's more chance to get your long term weight loss.
So when you are doing the health questionnaire and you put all the medication you take, including Ozempic, including blood thinner, everything you do take, it gets reviewed, and then you be instructed of when or which medication to stop and when to start back after
Yes.
surgery. Bring the bottles in its original, with the original labels with you, anything you take to Mexico, just as a reference. Okay, I had my gallbladder removed in 2001. With some complications, I have a big scar. Am I okay to get the gastric sleeve? Well, same question about incision.
If you have open incision from your gallbladder removed, we will try to avoid that scar because we know in that part of your abdomen, it will be a lot of scar tissue. So in case we need to remove the scar tissue, we will do it, of course, when we need the free way to do the sleeve. So the most probability is we will not use the same scar. Remember, we do the laparoscopic way. So it's a very tiny, very tiny incisions. And we start far from your scar to get free to go in. And then we see if we need to clean the scar tissue to continue with the surgery. If it's not necessary, we won't touch the scar, but we try to avoid that way.
That's another good question they're asking about blood work. Should I do my blood work before we arrive? And so basically, we are not requiring, but recommending you get your blood test done, especially with people who are coming for revision, because when you have had maybe a bypass before or sleeve, your hemoglobin could be low. And that's something we want to detect before you get there. And we can start working on it before you get there, so you just come ready to go. We do, of course, do our own blood test, but just have a regular blood test done, make sure your hemoglobin, everything checks. So another thing they were asking about the pharmacy and post-op medication. So post-op medication, we give you for pain, antibiotics. The only thing that you need to get, it's optional, is the antacid, like omeprazole. And that's not something that you have to buy there in Mexico. You can buy it there. You may not even need it. So this is just recommendation. So it's something that, and is mainly like maybe $10 or around $10 for 30 days. So,
Okay, I see one question about the gallbladder problems and with not gallbladder removal. It's more chance to get problems with the gallbladder if you already have problems. So it's an indicate to get out in the same surgery, the gallbladder, because it's a big chance to get problems after your weight loss. The weight loss in any way, if you are doing a diet, getting a bariatric, or for other questions, increase the chance to get gallbladder stones.
and usually, they've been asking a lot about revision. When you had maybe a sleeve and you didn't get to your goal weight, it's, coming and like getting a revision always works really good. So for COVID restriction, so we do recommend you do a COVID test for yourself and companion before you come. It's, again, is not required. but it's a good thing to do before your departure from home, and knowing that during your travel, when you go down there, there's no problems.
Sorry, I was checking the other questions, but what is the question?
Which one?
The last one? Oh, we go for the next.
The one for DS? So if they're asking if I have a poor metabolism, is DS a better option for me?
No, actually, you need to check the all the who involves your overweight problem. The DS is not the solution because it's more aggressive procedure. Sometimes it's better a bypass who is controlling all the aspects, and it's not too much malnutrition surgery like vaginal switch. Any surgery will help you. The low metabolism is from your overweight, and all kind of surgery will resolve the overweight. It will help you, so it will improve any surgery your low metabolism. And depends how is your BMI and everything.
Another question I have from Sandy, she says my cardiologist won't clear me for Mexico surgery. You say I'm high risk. Am I crazy at 70 years old to be wanting to do this? I also have dry mouth, arthritis in my lower back, and I'm concerned about no gum or meloxicam. I don't know what that means, but
I talk about that, the meloxicam, naproxen, all that kind of anti-inflammatory medications could be taken with not problem immediately after surgery. The problem is to be before surgery. Some days meloxicam is not a problem. It's ibuprofen, aspirin, naproxen. They are more blood thinner, but meloxicam is good, and you will continue taking after. And the other patients who have this problem with the cardiologist clearance, 70 years, I don't know how is your BMI. We need to see if you have a problem with the overweight, obesity, grade 2 or 3. We can give you the tool in a sleeve surgery maybe, and we can do an echocardiogram to check if you are in condition to get surgery or not. And well, we had patients in 70. We evaluate if you are in enough condition to get surgery, and if is necessary the surgery because you have a lot grade of obesity who justify the surgery. If you come and we do the cardiologist evaluation with echocardiogram, and the cardiologist here says you can't have the surgery, well, it's a risk too. If we do the pre-op evaluation and the cardiologist says, yes, she is enough strong to get the surgery, we can do it. But this maybe yes, maybe not. But if the cardiologist in US don't give you the green light to get the surgery, we need to check here with our doctors, but if our doctor says no, you won't have the surgery. So it's a risk, you know, but I can say for sure you will have the surgery. We need to evaluate your special case. How much BMI, if you have pre-op health conditions, a special condition in your heart or other organ. So it's a special case.
And there was one question about medical tourism insurance. So I put up this slide to show what the coverage is. So it could be any thing, complication with the surgery and any like travel related delays, and the maximum payable is $25,000. It covers 45 days after surgery, and it's $149. Again, the bariatric vitamins comes in the soft chew, chewable, drinkable, and capsule. I think we still have some questions they didn't answer. So can you talk about sex drive after weight loss surgery in general?
Talk about what?
Sex drive.
Well, it's normal when you be ready, when you don't feel any pain in your wounds. You don't feel, first days we feel like we are bloating all the time with gas trap, and that is uncomfortable. But if you feel fine, go. It's a green light to get your sex life normal.
One more question is, I have been known to have a vitamin D deficiency. Could that improve with successful bariatric procedure?
You don't have normal rates in your vitamins levels already? Or that is the question?
Yeah, so they have vitamin D deficiency. Is that going to improve with the surgery?
It need to be taking supplements, vitamin D, calcium, because it's important to be in normal rates, because you will have low rates after surgery if you don't take continuously, and if you already have, you will have more problems if you don't start right now. You need to start that supplements before surgery to be sure you will not have problems after surgery.
Okay, so we're almost at the 2-hour mark. So we usually try to be under 2 hours. So we have, well, I want to thank you, Dr. Valenzuela, for taking time to join us. I appreciate you, like always. And just have all the names that they were eligible, and they presented the webinar to the end, entered here, and I'm going to take one name out and see what that name is. So is Stephanie Andrade. Stephanie Andrade, let me see if I can find you here. Yeah, I don't see your name, or maybe you're in a logging in an anonymous, or you're if you can raise your hand. Otherwise, okay, we'll be in touch with you, and please make sure you contact your coordinator for any question. The recording of this webinar will be online. You can ask for that. Thank you again for Dr. Valenzuela. Thank you for everybody to join us. We see you soon. Appreciate it. Thank you. Bye-bye.
Bye.
Bye.